Welcome to this narrated lecture. This is Dr. Mary Day here, and the topic of this lecture will be on communication skills and how that relates to independent prescribing. The learning outcomes of this lecture are as follows. I hope by the end of the lecture that you understand the key aspects of communication during a consultation, that you understand how to communicate effectively with regard to ocular disease and prescribing of medications, that you understand how to adapt communication relevant for specialist diseases and medications and to take account of patient needs. And we'll talk about things like age, level of understanding, health literacy, as well as the patient's beliefs. And that relates to health, their understanding of health, treatment, medicines and their personal preferences. And lastly, to understand how to involve and work with the patient and or their carer in partnership so that they can make informed choices, exploring the patient or carer's understanding of a consultation and the risks and benefits of any treatment that's suggested. So this is how the lecture is going to run. First of all, we'll talk about why communication is important, what advantages good communication has. Then we shall talk about communication techniques throughout the consultation. So these are the techniques that you may use at various points throughout the patient visit. Then we'll focus in on history and symptoms itself and talk more about communication during that section of the consultation, and then more about the management and advice section and communication relating to that. First of all then, why is communication important? We're going to just take each one of these bullet points in turn and discuss them briefly. So firstly, and most importantly, are the GOC's standards of practice. You can find a link at the bottom of the slide to those GOC standards. So from the PowerPoint, if you'd like to see the active version of that, just click on that link that's underlined at the bottom of the slides. What I've done over the next few slides is just take a screenshot of the contents of various sections within those standards. Just as a reminder, the GOC standards are the standards of practice for optometrists and dispensing opticians. These are the generic standards that apply to all optometrists and dispensing opticians, not just to IP. And these are the standards to which we all must adhere during our practice. These are standards, they aren't guidelines, and as such we must do these things. There are 19 overarching statements or standards, and each one of them has multiple bullet points within them. So I've copied all 19 here for you to look through. Feel free to pause the presentation and read through them all. But the four that we are focusing in on today and relate to communication are the first four there. So I'm going to take each one in turn and just show you the bullet points underneath each one of these sections. First of all then, listen to your patients and ensure that they are at the heart of their decisions made about their care. I'm not going to read through each one of these bullet points. I think you guys can do that yourself. So again, feel free to pause the slide and just read through the subsections of this standard. The second standard is that you should communicate effectively with your patients. Again, you can feel free to pause and read the individual sections within this. Then we have obtain valid consent. We will be talking about this in more detail throughout towards the start of this lecture, but again, feel free to pause the slide and read through the individual parts of these standards and what it's saying about consent. Then number 4 is show care and compassion for your patients. This obviously you would do this through communication. There's 2 points underneath this, so I can just read them quickly for you. Treat others with dignity and show empathy and respect. Respond with humanity and kindness to circumstances where patients, their family or carers may experience pain, distress or anxiety. Okay, next is the College of Optometrists Guidance for Professional Practice. Here I've provided the information about how you'd reference these guidelines and also a link to the guidelines if you want to look through them. I'm not going to read through them throughout this lecture, but I think it would be useful for you all to just click on the link and read through what this guidance is saying. So this guidance is the guidance relating to those standards. It's tips and practical suggestions as to how to put the GOC standards into practice. Some of them can be quite useful, and as I said, I think particularly relating to communication for this lecture, you should take a little bit of time and read through them. Next we move on to the third bullet point here, the GOC's requirements for prescribing. Again, at the top of the slide I'm providing a link to these requirements. I'll be talking a lot about these requirements through this lecture, and just so that you've got a bit of context to these were published by the GOC in 2021 as part of their educational review, and what they did was took the Royal Pharmaceutical Society's competency framework for all prescribers, so that's the bottom link that I've got, and they've adapted them and tweaked the wording of them to be relevant for prescribing optometrists. These again are standards that we should be working towards as IP optometrists, and I'll highlight many of these throughout these lectures, but you get the link to the full version. Next then, the OCCS. The OCCS is the Optical Consumer Complaints Service. This is the body which helps with any complaints at the practice level which can't be resolved within the practice. Often cases are referred to the Optical Consumer Complaints Service to try to help resolve, and they produce an annual report each year, and in almost every single year there are similar themes that are published within their summary report. And if you look through the reports, which you don't have to thankfully, because I've done it for you and summarised them here, there are 2 main items that come up time and time again with patient complaints. The first one is that inadequate communication is the most frequent cause of complaints. So if you are able to provide good communication with your patients, then hopefully you would minimise these complaints. And often it is a problem with the optometrist's explanation and or the patient's understanding of what is being said. So again, it's important that we try to get these explanations correct, and we try to make sure that the patient's understanding of what's being said is also correct. And that's not just the patient's responsibility, that's the responsibility of the practitioner to work together with the patient to help the patient understand what's being communicated to them. The next item on our list for why is communication important is consent. Consent, as you probably gathered from the GOC standards, is a really important part, and communication is integral to obtaining valid consent. So I've just added in here the main take-home messages that we need to understand about consent. So consent is required before any procedure or treatment is undertaken, and consent is only valid if the 3 points, and all 3 of the points, are fulfilled. So if the patient has the capacity to consent and the patient has been informed about the procedure, and that includes the advantages and disadvantages, the reasons for doing that procedure, and that they have the understanding about what they are consenting to. And obviously, as I said earlier in this slide, communication is integral to obtaining consent. Next on our list is concordance with treatment. Here's actually hopefully an interesting fact, which most of us may well find a little bit surprising on first glance. On average, 50% of patients do not take their medicine correctly or not at all. If you think back to when you've been given medication to take, did you take it correctly? And if you didn't, why didn't you take it correctly? Now, admittedly, that on average 50%, there's a big range between the studies, so it can be between 10 and 90% of patients. And as you'll hopefully see in the next slide, concordance depends on lots of factors. Listed on this slide then are the most common reasons for non-concordance of patients with treatment. The top bullet point here are patients' beliefs, and this actually could be a range of beliefs which could impact on whether a patient takes their medication or indeed implements any suggested treatment. It could be their own beliefs about medicines, taking medicines. It could be their beliefs about the condition itself and how bad they think the condition is versus the advantages of taking the medicine. It could be their beliefs about how well the treatment might or might not work. So you really need to explore the patient's beliefs to try to reduce the possibility of them not being compliant with the treatment that you end up deciding on with the patient. Perceived benefit, I kind of alluded to that in the previous few sentences. The benefit that the patient perceives they will get from this compared to the risks or the disadvantages of undertaking the treatment will have an impact on how well they implement their suggested treatment. And again, the third bullet point here I've talked about already, how well they understand the instructions of when and how to take the medication, how well they understand the condition and the treatment and its advantages will all have an impact on how well they comply with taking the suggested medication. The patient-practitioner relationship is really important. Hopefully you see already that the top 3 bullet points are clearly related to communication and how you communicate those various elements with the patient. But the core of the relationship between the patient and the practitioner are also important. The patient has to trust the practitioner that what they're saying is in their best interest, that it's, valid and correct information that they're receiving from the practitioner, and also if they genuinely like the practitioner and are happy, would like to please them and to go along with the treatment and what they're asking of the patient, that all has an impact on concordance. Then we've got convenience. We need to make sure that any treatment that we're suggesting, any medicine that we're prescribing, is as convenient as possible for the patient, that it fits in with their lifestyle and is as easy as possible to do. So here we're thinking about the number of drops. You might choose one if there's a certain patient with a certain lifestyle. Taking a drop once a day might be much more convenient to them than taking it 3 or 4 times a day. The time of the day that they take it, again, think about what they work as, when might be easy for the patient to fit taking this medication into their lifestyle. Forgetfulness is a big issue. A lot of patients just forget to take it at the certain time. So again, trying to talk to the patient and work with them to find a solution of some sort of alert or a reminder if they do take their eye drops whilst they're brushing their teeth or whatever that may be, to reduce that forgetfulness aspect. There might be a physical inability to open or use the, particularly this can be a problem with eye drops. I've sat in on a clinic with Dr. Siddiqui, who's a glaucoma specialist, and he tells me that he now watches every single patient pop their drops into the eye because he, over time, realised that a lot of the glaucoma treatments were ineffective because the patient just couldn't insert the drop in the correct position. They weren't putting it in their eye, they were putting it down their cheek. And so, taking one step further, the actual ability to physically open the drop or physically squeeze the bottle can have an impact on how well they use it. Side effects. This is obviously a big one. If the patient's getting stingy eyes, irritated skin, or any number of the other potential side effects of the eye drops, they might stop using them or reduce their use. The best way to do that is, again, through communication. If we talk to our patients about what these side effects might be, and if they start experiencing any side effects that are impacting on how they use the medication or are severe, then they should come back and talk to you about that, and you can make adjustments to their treatment rather than them just not taking the medication. And then another reason for non-concordance is a mistake in administration or dispensing, that it's actually dispensed wrong, the wrong instructions are on the packet, etc. So on that note then, which of the following do you think has the best relationship with the resolution of a chronic headache? The ability of a patient to get a diagnosis, to undergo investigations, the discussion with a practitioner, get a prescription, or get referred. And just leave it a wee second. You feel free to pause if you want longer before the next slide. And the answer is possibly unsurprising given the context of our discussions, but C, a discussion with the practitioner. Now if you actually think about that for a second, I think that's quite amazing. Chronic headaches can be fairly debilitating for patients, and if the best relationship with the resolution of that headache is a proper in-depth discussion with the practitioner, then I think that's a fairly easy resolution for those patients, and a really important one actually. I'll give you another couple of useless bits, that's not useless of course, but surprising and slightly off-topic bits of information. So the duration of a sore throat can be predicted by the patient's satisfaction with the consultation and how well the doctor deals with the patient's concerns. So again, that has communication has fairly major implications in the duration of a sore throat. And then in a slightly more serious condition, myocardial infarction. So if a patient's had a myocardial infarction, their need for analgesia after that event is actually related to the information giving and the discussion between the practitioner and the patient, how much they can have a reduced need for analgesia if they have a satisfactory discussion. So I think that just shows how important communication is in relation to adherence. And then just the last fun fact on this part, improving concordance, or a bit of a summary here. The patient's perception of your communication is the most important factor in obtaining a reduction in symptoms, an increased satisfaction, and an increased adherence to treatment. So hopefully you can see how important communication is in terms of disease and treating and prescribing. Next then, patient satisfaction and retention. If we have good communication, then the patients are likely to be more satisfied and you're more likely to retain them as patients going forward. And also then the last bullet point, practitioner satisfaction and litigation. If they're satisfied, they're less likely to bring a complaint or any sort of legal action against you as an optometrist. So that hopefully in a relatively small amount of time summarises why communication is so important generally throughout the consultation, but also particularly as IP optometrists. Now we're going to delve into the real meat of the lecture. We're going to talk about communication techniques. These are general communication techniques that we should use throughout the consultation. Now some of this may well be a little bit of revision from your undergrad. Hopefully it will act as a reminder, and then we will talk specifically about prescribing on top of the more generic communication skills that you might already be aware of. So first of all then, communication techniques throughout the consultation. And by throughout the consultation, we're talking about the history and symptoms, the management, and everything in between. So this slide has a lot of information actually. The information within the next few slides comes from the Cambridge-Calgary guide. The guide itself has a long and a shortened version, and I've posted both of these versions on GCU Learn for you. You can buy the book, but we've extracted the relevant sections and posted it on GCU Learn for you. I would spend a bit of time reading through this. I'm going to summarise some sections of this within this lecture today, but it would be very useful for you to take the time and read through these guides. They're really succinctly summarise the communication techniques and provide a bit of extra information that might be useful to you. So these here are some general communication techniques that you use throughout the eye exam. And I'll just go through each one briefly, giving a little bit of an explanation of what each one is. So the first thing that can be really useful throughout the eye exam and throughout history and symptoms and the management is to use signposting. So this is where you signpost, you tell the patient what you're about to do or talk about or ask and why. So it might well be that during history and symptoms, for example, you've followed up all the questions about their main complaint, and you're now going on to talk about their general health. So you might want to say, now we're going to talk about your general health. This can be applicable to your eyes, or some signpost to suggest that you finish with the previous thing, you're going to start in the next thing, and a brief reason sometimes as to why it's appropriate to ask these things. You'll know yourselves, particularly sometimes during history and symptoms, patients will look at you funny when you start asking them lots of details about their general health. So a simple explanation as to why you're asking those questions can also help with that patient-practitioner relationship that we spoke about before. It also helps when you go between sections of the eye exam. So that's us finished talking about, that's us finished me asking you lots of questions now. Now we're just going to move on and I'll take some measurements from your eyes, something like that. The next bullet point then, open and closed questions. I think you'll probably all be very familiar with what that is. So an open question tends to be something that requires more than just a yes or no answer. You generally use open questions at the start of a set of questioning so that the patient can talk through fully what, for example, their main complaint complaint is, and you might then end up talking in a little bit more, you might end up with some closed questions to clarify information. Is that in the right or left eye? Is that this type of pain, etc. So you would use a mixture of the open and closed questions throughout your eye exam as appropriate. You want to be alert to the fact that you don't want to use any jargon. So jargon's health or eye related terms that a patient might not understand. So refraction, ocular, that kind of thing. Try to put everything in the patient's language. This next one, strings of questions, is something that we can be quite guilty of. So do you get any flashes or floaters? Do you get any headaches or double vision? That type of thing. That's a string of questions, and that ideally should be avoided. So when I'm talking to the undergrads about this, I try to give them a situation where, let's say you're going to your GP and your GP asks you, how's your hearing in your right ear and your pain in your left hip and the extension of your right knee all at one time. What you would have to do as the patient is try to remember the first question that you were asked, try to then think about your answer to that pain in your right ear that you were asked about and reply to that. They then have to remember the second part in the string of questions, which was, I can't even remember their left hip and the pain in that, how that was, and they have to answer that. And then they need to go on to the extension of the right knee that the GP was asking them about. That isn't helpful for the patient. It would be much better from a communication point of view to ask them about their hearing in their right ear, let the patient answer, and then ask, for example, the pain in the left hip. And that premise stands for all of the eye related questions. Ask them about each thing individually rather than giving them a string, which is just difficult for a patient to remember. You don't want to have any leading questions. So these are questions where the patient is led into answering one way or another. And again, I think a lot of us are quite guilty of using some leading questions. So your general health is fine then, no medications, no headaches. So the vision's good in the right eye then. All of these things are leading questions, and it would be much more appropriate to ask, do you have any headaches? How is your vision in the right eye? Do you think your vision is good, or would you say it's reduced? That type of thing are more balanced, unbiased questions which lead to a more effective answer for the patient, and you're not leading them down any specific pathway. And then the last general communication technique on this slide is chunks and checks. This mainly pertains to management and advice, but it can be used at other points within the consultation. So if there's a time where you're providing a chunk of information or a large volume of information, or you're talking about a big topic, then what you should do is break it down into small chunks. Just give them a manageable chunk of information, and then you pause and check the patient's understanding and if they have any questions relating to that. We will talk about chunks and checks, we will talk about patient's understanding and how you might broach that in the coming slides. Just following on then with some additional general communication techniques that are used throughout the consultation. On this slide we're concentrating a little bit more on the non-verbal communication aspect. So you want to first of all make sure that you're listening attentively to the patient, picking up on any clues or cues that are a little bit less subtle, and also on the more obvious ones you need to make sure obviously that you're listening properly to what the patient's telling you. When the or if a patient was to give you a more subtle verbal or non-verbal cues, it is our responsibility to pick up on these, even if at times that's not going to be what we feel like we want to do, because often these things are either more difficult to address or take up more time from our precious consultation time. So, but it is important that if a patient looks like they're saying yes, but it looks like from their non-verbal cues they actually mean no, or they're not comfortable or not happy or not in agreement with what you're describing, that you want to pick up on these and address these, because that feeds into what we've already been talking about the concordance issue. And throughout the consultation, you want to act with appropriate non-verbal communication. Now, there actually could be a whole lecture just on non-verbal communication, so I'm just summarising it here. I've summarised the 5 main aspects of non-verbal communication. It's often that we think about non-verbal communication being body language, but don't really think about the other aspects of it. So body language is composed of our use of our hands and our arms, our head and shoulders, and our legs and our feet, and each individual element of the body has a whole set of things and ways to express ourselves, and has implications on how we are holding ourselves in all of these different positions. Our posture, whether we're leaning into the patient, away from them, etc. Our facial expressions feed into that body language, and gaze and eye contact, how much or how little eye contact can also have an impact in the overall patient-practitioner relationship. In addition to that, the paralanguage, so the actual vocal cues, the tone and pitch and speed of the voice are all part of that. The space, so how proximal you are to the patient. Obviously at times we have to get within the patient's personal space, and at other times just think about how far away from a patient you are at the various aspects of your consultation. Touch, we're talking about general touching during communication, how that might make a patient feel. It might be appropriate to do it in supportive situations and less appropriate to other people. It depends on who the patient is, what their beliefs are, and who you are in relation to them, age, gender, etc. And that all has impacts on how appropriate using touch is or isn't in the consultation. And obviously we have to touch the patient's face and eyes at times as well. That can also have an impact. And then the last aspect of non-verbal communication is your personal appearance, how you dress, how your hair, face, nails, etc. appear to the patient, can all have an impact on how of your communication relationship with that patient. And then last slide on these general communication techniques then. During the consultation we want to make sure that we show empathy for the patient. So that's not sympathy, pitying them, that's showing them that we understand the way that they're feeling, try to take into account that and help them through that by our explanations, understanding and altering or accounting for that within our management of the patients. Clarifying unclear information, that's obviously important both from the patient and the practitioner point of view. And then now we're coming towards the end of the consultation. You want to provide summaries at pertinent points, a short summary outlining the main aspects of what you're doing or what you're wanting the patient to do or to understand is really important, and repetition improves concordance. It improves how the patient memorises what has been said during the consultation. Retention of consultations is fairly poor. Patients will tend to remember the elements that they think is important. They will tend to remember if you give them a large screed of information, then they're more likely to remember the very first part of that and less likely to remember the rest of it. This is where the small chunks and checks comes in that we spoke about on one of the previous slides. And also, it's really important to check the patient's understanding. Now, often when I'm in interactive sessions with you guys, someone will bring up, is it not quite condescending to a patient to say, can I check that you understand what I've just said, or how would you approach that? Understanding is not just the responsibility of the patient, it's the responsibility of the practitioner as well. And I suppose the way that I would tend to check understanding is say something like, I'm aware that I've given you a lot of information there. I want to make sure that I've not missed anything or explained anything in a way that wasn't the best. So is it possible for you just to repeat back to me the main things or what you understand from what we've just spoken about? Something like that's a nice way to check the patient's understanding. And often, again, if you think about back to any consultations you've had, some of my experiences are in a maternity setting, so during the consultation I'll think, right, yeah, the person will have said to me, do you understand? And I'll have said, yeah. And it's only when I go outside and I go to phone my mother or my partner or whatever, that suddenly I realise that I haven't actually understood things as well as I thought I had done. And that's maybe a bit of memory. So getting the patient to repeat back what they say will increase their retention and will also help check that they actually understand what you've said and all of the intricacies of that. Now a couple of slides on topics relating to communication but are probably less talking about the detail and more overarching considerations. So it's really important that we undertake the consultation in an appropriate setting, taking account of the following three things, and this is obviously in line with regulatory practice and contractual agreements. Confidentiality, we need to make sure that when we're talking to a patient about them and their condition, we do it by respecting their confidentiality. Think about where you do it, and is it in a closed room where other people can't hear, or is it beside the non-contact tonometer or autorefractor, which is in earshot of other people. And also that links into dignity and respect, making sure that you are giving the patient the utmost dignity and respect whilst communicating with them throughout your consultation. And then consent. This is where we'll just spend a couple of slides talking about the importance of consent. This here is a reminder of the previous slide, just to remind you what valid consent is. So the consent is valid if a patient has the capacity to consent, been informed all about the procedure or intervention, and they have the understanding about what they're actually consenting to. It's generally assumed that every adult has the capacity to make decisions. However, a person would lack capacity if, for example, they've been given all of the appropriate help and support, yet they still cannot understand, retain, use or weigh up that information. So it's our responsibility to provide the information and support the patient and help them as best we can to understand the information, to be able to retain it, and then to use or to be able to weigh up the advantages and disadvantages relating to what you're talking about. But if you've done all of that and they still can't understand, retain or weigh up that information, they would be said to lack capacity. They would also lack capacity if they cannot communicate their wishes. So what does this mean in terms of treatment for us, really? If a patient agrees to something but they do not really know what that intervention entails, then they're not consenting to it. They need to be told about the treatment, what the intervention entails and the risks and benefits. And all of that information needs to be given in a balanced way to the patient. If you recommend a specific course of action, so you could say, we could do this, these are the advantages and disadvantages, risks and benefits. We could do that, these are the risks and these are the benefits. If you decide to recommend, so I would recommend X and the reasons for it, because these advantages are more than those disadvantages, etc. So you'd want to give the information in a balanced way, giving reasons if you are going to recommend a specific course of action, but not put any pressure on the patient to accept this. And if the patient does refuse treatment or any intervention or to undergo a test, then you as a practitioner should respect this. And along those lines then, what we need to do during communication with the patient is assess the communication needs of the patient and carer and adapt our consultation appropriately. So that might be to do with the language that you use or the language level of the patient or carer. Their age, again adapting your communication to the appropriate age of the patient and to their capacity, so what they're able to retain or understand, and you using language at the level that's appropriate for the patient. And we also want to assess any physical or sensory impairments and again make allowances and alter our communication so that it can be optimum for a patient with any physical or sensory impairments. And last point then on general communication, we want to really build a rapport, or we need to build a rapport with the patient or carer, and that's again alluding back to the patient-practitioner relationship, to get a good rapport with the patient or the carer and the carer, so that communication is optimum throughout the assessment. Okay, that's us got through the second bullet point then, the communication techniques that are applicable throughout the consultation. What we're going to do now is move on to history and symptoms and talk in a little bit more depth about communication at that stage of the consultation. Within this history and symptoms section, we're going to break this down into two subsections. Firstly, communication relevant to history and symptoms that's applicable to all types of consultation, so not just relating to disease and prescribing, but any patient consultation that an Optum might face. And then we're going to delve a little bit more into the more specialist communication relating to ocular disease and prescribing of medications. So first of all, if we go through history and symptoms and the communication applicable to all types of communication, so general history and symptoms communication. First of all then, at the start of history and symptoms, it's really important to greet the patient appropriately. This is building into the building a rapport with the patient that we spoke about earlier. And after greeting the patient appropriately, it's really important to introduce yourself, and not just your name, but also the role that you hold. Have you ever been in a hospital or a GP's surgery or a dentist and you have no idea who this person is that's talking to you? I know I have quite often, and it can be quite awkward for the patient if they don't know who they're talking to. So by introducing yourself by the name with which you would like to be addressed, you also want to confirm the patient or carer's identity, know their name, again learn how they would like to be addressed, Mrs. Smith or Angela Smith or Angela or another nickname. That's all part of that introduction. As an optometrist, you want to say to the patient that you are the optometrist, and you may well want to add in as a prescribing optometrist that you have a prescribing role, and that way the patient knows exactly who you are and where they sit. And then you're on to the opening question, the usual "what's your reason for coming in today" type thing. There should be an open question, and you should definitely pause even after the patient has told you the initial reason for coming in. It's often useful to pause, maybe with a nod or an acknowledgement that you are listening attentively, but allowing them to continue to speak the information that they would like to. It's actually much, especially if a patient's coming in with a disease problem or something wrong with them, despite what we often think it does tend to be that the patients will think through what they need to tell you, and it's often more appropriate to let them speak and say their full spiel rather than to say a little bit and then for you to jump in with all of these closed questions. So try not to interrupt the patient, pause and encourage the patient to tell the whole story in their own words. And then you want to summarise and screen that you've understood correctly and that you've got all of the relevant information. Now again, I'm kind of taking a slight tangent to give you some facts about that main complaint, and hopefully some are interesting and hopefully it'll help inform your communication further down the line. So this is surprising to me. The patient and the clinician disagree on the patient's main concern in 50% of cases. So think about that. What the patient thinks might be their most important thing, might not be the thing that you think is their most important complaint or concern. And so you need to address both the main concern of the patient, but also what you think is the most important or pertinent concern. And knowing that fact can often help inform the way that you do that and communicate with the patient. Just understanding that what they think is the most important isn't often what you do, and then talking them through that. Not very positive statistic in the second bullet point here: up to half of patient problems remain unidentified by the clinician. So up to half of patient problems you won't know about. And patients might not tell you some information or the medical professional information for a number of reasons. So they might have a preconceived idea that it's either not important, nothing can be done about it. It might be that they don't want to be a burden or a problem patient. Less for optometry, I think, but it can be applicable. Patients might have a worry that their worst fears might actually be confirmed and that there is something fairly bad going on with the patient's health. And then there's also blocking behaviour that healthcare workers can act. So they might jolly the patient along or dismiss the patient's fears or distress. The healthcare worker might attend to the physical problems but less the psychological needs, or a healthcare worker can kind of jump in with advice and reassurance without listening fully to the main complaint. The other thing to add actually is that often the first thing the patient tells you isn't their main worry or their main complaint or the main reason for visit. So having that pause in there whereby you ask them, why are you in today? And they may well say, oh, just in for my yearly check, whatever. And then it might only be after building rapport with them or by pausing and showing that you're interested and is there anything else that you would like to discuss today, something like that, then can bring out the actual reason why they're in. And so hopefully with that in mind, just going back to the slide that you saw one before the last one, just working through that opening question. Have an open question, pause, let them say everything that they want to say, and then you summarise and screen for any additional information and check your understanding of what the patient's told you. And then if the patient does have a certain symptom that you need to go into in more detail, you'll all be familiar with all of the additional questions regarding that main complaint. So the time of onset, mode of onset, duration, nature and frequency should all be asked in relation to the time course of the symptom or the complaint. And then you need to remember to ask about all of the associations relating to that. So does anything make it start? Does anything make it stop? Does anything make it better or worse? Or a general question, is anything associated with any other symptoms? And has anything changed recently within your life or within your eye health or general health that it could be associated with? It's also important when the patient has a problem that or a reason for visit that they're coming in for. It's quite important at that point in time to explore all of these things on the list. Again, these relate back to the concordance issue we spoke about before. Try to understand what the patient believes or their perception about said eye disease or using certain eye drops or whatever, what their concerns are and what their expectations of the visit are. So it's all very easy for us to assume that the patient is concerned about one thing when actually they may well be concerned about another. So it might be that you think they might be concerned about going blind, whereas in actual fact they're concerned that they're not able to put the eye drop in because they have rheumatoid arthritis in their fingers and they've not got very good manual dexterity. And obviously both of those concerns are very different, and you need to be able to understand the concerns so that you can tailor your explanation towards what they are actually concerned about. And the same with expectations. What is their expectations of the consultation and what's going to happen, and have you met them later on in that consultation? You want to explore the physical, emotional and social impact of the patient's problems on them, on their family, again, so that you can help address these and what their general feelings are at the moment and towards the condition or the treatment that they're undergoing. And then towards the end of the history and symptoms, you want to summarise the main points. Obviously invite questions or ask them, is there anything that you've forgotten or anything else that they would like to talk about in relation to their eyes. And then that's signposting. So now you signpost them to, we've done the history and symptoms, now we're going to move on to the examination part. Those in the last set of slides were all history and symptoms generally relating to most or any patient consultation. We've got some additional kind of specialist communication skills to think about in relation to history and symptoms pertaining to disease and prescribing in particular. So this next one is an outcome on the GOC's requirements for IP, and again you've got the link below. And this outcome says that a prescribing optometrist should build a relationship which encourages appropriate prescribing and not the expectation that a prescription will be supplied. You'll know that there's a bit of an issue with patients going to GPs expecting to get a script and some drugs, and that's not often the best intervention or the most appropriate treatment for that patient. So in doing your history and symptoms, that's where this starts, where you're talking to the patient about prescribing if that's appropriate, and you'll consider all of the possible relevant management options. This slide talks a little bit more about additional content that you might want to include within your history and symptoms that's relevant to disease and prescribing. So obviously, as we've talked about in the previous slides, you want to conduct a full history, and that includes the questions that are relevant to the presenting complaint. Again, we've just spoken about what some of these might be. So in addition to that questioning about the presenting complaint, you want to also ask questions of the patient, specifically addressing the risk factors for the condition or conditions that you think they might have at this point in time. So it might be, let's say you think that the patient might have episcleritis or scleritis. Although you've asked them, how's your general health? They've said fine. You want to ask specifically about certain conditions. So have you ever been suspected of or have rheumatoid arthritis as an example, inflammatory bowel disease as an example. And you could go one step further than that. So a really good consultation might have, so you ask the patient about rheumatoid arthritis, they say no. One step further might be to then ask about some symptoms of that. So have you ever had any aching joints, problems with your hands and feet, etc. So that you fully explore the risk factors relating to the conditions that you are thinking the patient might have. And then thirdly, you want to include questions that are relevant to any drugs that you'll potentially prescribe later on. So often a general question here about allergies or any intolerances that they've had to anything, including eye drops, systemic medication, or any other allergies that the patient have, is really useful to ask at this point. You might want to consider asking the patient, just in your list of questions really here, about pregnancy, breastfeeding, contraception. Now, it might be that you decide that that's not appropriate to ask every patient, and it might be that later on, once you know which medication you're prescribing, and if that's mentioned, these things are mentioned within the BNF, then you would need to address them at that point, but you may not need to ask that of every patient. And this is the GOC outcome, which is kind of alluding to what we've talked about in the previous slide. So the outcome says that IP Optons must take an appropriate history, including a medical, social and medication history, including allergies and intolerances. So I think we've talked about most of that. And now we move on to the last part, which is the management and advice. Again, management and advice will be split up into two sections. We'll talk firstly about communication that's applicable to all types of consultation, and then focus in more specifically about the specialist communication relating to ocular disease and prescribing medications. Next of all then, management and advice, communication applicable to all types of consultation. This is a summary of the general communication techniques. So we want to involve the patient in the decision-making process. This slide here just again has hopefully a couple of useful nuggets of information, statistics about the general population, etc. So the first couple of sentences are from a study in 2004. So we're talking about 24 years ago, and this might have changed a little bit by then. But even at that point in time, the vast majority of people, so about 2/3 of patients, want to be involved in their decisions about their treatment, and a minority, 32% of patients, wanted the practitioner to decide for them. So I would anticipate that 64% has probably gone up a little bit and the 32% down a bit. in the last 20 years. However, so what does that tell us? Most patients want to be involved in the decision-making process, but there are a small minority who just want us to decide for them. So what you want to do is talk to the patient. I think it's always our duty to give all patients the advantages and disadvantages of each, but to tailor that to the patient, how much they can take in, how much they want to take in, and also an understanding of whether they want you to just recommend something or whether you want to go through a longer discussion and giving them, as we've talked about before, a balanced approach of the advantages and disadvantages, and whether they want you to suggest which one might be best and the reasons why, or whether they would rather have all the information and make the decision without your recommendation. The second part of this slide is actually another thing to think about, is the age of the patient. So this is a graph on the y-axis. It shows you the percentage of patients who want to be more involved about their decisions, about their treatment, and this is stacked by age. So again, you can see that the patients under 40 wanted to be more informed than they were, whereas the older patients, only 50% of them wanted to be more involved. So the assumption is that half of them were happy with the amount of involvement they had. Caveat here is that this was a much older study from 1980, and the percentages may well have changed, but the overall message may still be the same, that more older patients might want to be less involved than younger patients, more involved in about the decisions about their treatment. So these are hopefully useful things to bear in mind when you're talking to patients and involving them in the decision making. So as well as involving the patient, these techniques are the important ones relating to management and advice. So give the patient the information in small chunks and check for their understanding, check whether they've got any questions, etc. before you move on to the next section. We've spoken about the last two bullet points already, so I'll not go into them in huge amounts of detail. Just remember repetition, 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 and to check the understanding of the patient. This is a wee statistic that I've added in here. So asking patients to repeat in their own words actually increases their retention of what's been said by 30%. When we're talking about giving a patient this advice, I think I said already that the patient will tend to remember the things that they think are important. If you're giving a big chunk of information, the patients might remember the first thing that you said. Patients can also remember the last thing that you said. So if you want them to remember one thing, you might think or rethink about the last thing you say to them being, you know, enjoy the football this afternoon or something, and rather make sure, remember, you take that 3 times a day and come back to me in a week. So these are hopefully useful tips that might help in the management and advice section. In addition to providing them with the information, you want to elicit the reactions to the information that you've given, and any concerns or questions or things that they think might not work about the management plan. So like we spoke about in the history and symptoms section, you want to address the patient's beliefs, their understanding, their concerns, go back to those expectations that they had and have you fulfilled what they wanted from the visit, etc. Summarise the main points, and I would say throughout invite questions from the patient. That's often a nice way to end on, just double checking again, do you have any other questions at all here? We've spoken about this already. Right at the start of the lecture, you need to have in mind the health literacy of the patient and adapt your management and advice according to that, to make sure that from the patient's point of view it's clear, understandable and accessible, the information that you're providing to them. So So we've spoken about the general management and advice communication techniques. Now we're talking about specialist communication skills relating to disease and prescribing. And we'll do that in 3 sections. General section, just general advice, and then we'll divide it up into a specific section with things to cover when you're initiating treatment and then during a follow-up visit or visits. So in general, there's a suggested structure to how you provide management and advice to a patient if they have a disease or if you're prescribing to them. So I'll go through this in a fair bit of detail over the next few slides. The first thing, it's often helpful to relate back to the patient's history and symptoms. That means you come in with a red eye and a sore eye, or you came in telling me you were concerned about X or Y. So that summary, that kind of brings them back to the start, reminds them where the whole consultation, what it started with. And then the second thing to do is you want to describe what you found. So describe your findings and show them maybe pictures, etc., or talk them through the results of the tests that you found. Now, often practitioners, the most important thing to them that they want a patient to understand is about the management and what needs to be done about this. But research shows that patients want to know about the diagnosis, about the cause, and about the prognosis. And there's no point in going on to discuss with them all about the management if you haven't answered the questions about what they've got, what the cause is, and what the prognosis is, because the patient's not going to be thinking about your management or even listening to you. All they're going to have in their head is, but what's caused this, but what have I got, etc. So the best formula seems to be to address that with the patient first of all. Talk to the patient through the diagnosis, what the name of it is, because they often want to Google it, what that means in real terms. You know, you've got anterior uveitis, this is an inflammation of a part inside of your eye. Then talk them through the causes. Often patients are concerned that they've done something. What have they done to cause that? How could they have prevented this from happening? And often with eye stuff, particularly the anterior uveitis or episcleritis, we often don't know what the cause is, and that can be quite useful for the patient to know that. Otherwise, if there is a known cause of an infection, injury, you know, underlying systemic disease, then it's useful to talk them through that. And then talk through the prognosis, so what's likely to happen to them in the future. This should recover by itself in 7 to 10 days, or, you know, you're going to need medications. If without medications, this is likely to get worse. So with a medication, this is likely to improve over the course of 2 or 3 weeks or whatever. So give them some time scale and tell them what's likely to happen to this in the future. And then that will allow you to then, once you've got all of that out the way, you've addressed their questions, you've fully talked them through that bullet point 3 there, then you can move on to the management. And this slide just summarises just what I've said. Tell the patient about their diagnosis, the cause and the prognosis, because that's what patients place importance on. That's what they want to know about. So now here we're going to focus on points 4 and 5. You want to go through the reasonable management options with the patient and involve the patient in the decision making of which is our chosen management option. So how do we do that? You want to explain the following in a way that the patient or the carer can understand so that they can make an informed choice. You want to talk about the risks and benefits of any treatment that you're suggesting, and the rationale behind each of the management options that you have. Why might they want to choose that? What are the risks and benefits? You also want to consider the relevant patient factors and how that might impact your choice on, say, the formulation of the medicine. You know, is it a thick gel, or is it going to be an eye drop, or is it going to be something that they take orally or in, you know, topical administration. All of the relevant patient factors go towards that, and you need to discuss that with the patient because it will have an impact on them. So what they do for a job, whether an ointment could be too thick and stay an impact on their vision for 5 minutes or so after insertion, how would that impact what they do day to day? What about how often they take it? How would that impact on their lifestyle? And as I say, do they have anything where they would say not very good manual dexterity, where eye drops would be difficult and an oral medication would be preferred? All of these need to be considered when deciding on the most appropriate management option for the patient. And some things actually which are quite easy to forget about or not realise fully what impact they have. So there are other factors which might unduly influence prescribing. So it might be interactions with the pharmaceutical industry or media, and this can be relevant for both actually the patient and the practitioner. So what are the patient's preconceived ideas about pharmaceuticals? Have they read something about it's bad to take, you know, a certain medication? How are the media portraying both the disease and the medicine that you're talking about prescribing with the patient? And then also think about, from a practitioner's point of view, how might you be influenced by what you've seen by that rep who came in the other week? What you've seen on the media, has that influenced unduly your decision making and deciding about a certain medicine? So then, of course, anything to do with the patient might influence your prescribing and what you choose. Their opinions obviously will matter. Possibly you may be influenced by opinions of your colleagues or what they've done. Take that into account when you're thinking about what the most appropriate management is for this patient. Then this is actually a really interesting thing. There's cognitive bias questionnaires that you can do actually. So everyone has a bias towards or away from something, and that might be in terms of disease. From a practitioner's point of view, you might be biased towards a certain medication or away from another, and the same with the patient. There might be lots of underlying biases that you have which might impact on prescribing, so you need to be aware of what they might be for you as an individual and then try to mitigate against them. And then, of course, a practitioner might have prescribing incentives or targets that they have to meet, and that may unduly influence their prescribing. In addition, within your management and advice section, some of these points actually already cover some of the things we've talked about already, but I think it's good just to have them all written down because each one of them is one of the GOC's outcomes. So you want to actively involve and work with the patient in partnership to make informed choices, and we've spoken about how best to do that. In doing that, you want to respect the patient, the diversity, equality, their personal values and beliefs, and that's about their health, treatment, medicines in general. Make sure that we're respecting all of those elements of the patient and the decision making that we're taking part in. We want to make sure, the third bullet point here, that we make prescribing decisions based on the needs of the patient and not on the needs of the practitioner or the practitioner prescriber's personal preferences. And And of course, you then want to agree a plan that respects all of those preferences, including if the patient wants to refuse or reduce the amount of treatment that they're doing or having. So that was points 4 and 5. We've talked about talking about all of the options and then involving the patient in the decision. Once we've made the management decision, we've got other things that we need to communicate with the patient. We now need to explain to the patient what that management entails and what will happen next. So I've tried to summarise the main points that are involved within this slide. You want to describe and explain all aspects of the care plan going forward, and the immediate next steps. So you might want to give them an overview, you know, I'll want to see you several times over the next few weeks. And the immediate next steps. So what that means is, how do they get their medication and what do they need to do right now? They also need to know about what to do if the action plan isn't working. So if they get to the pharmacy and they don't have the script, or they don't understand what's written in the script, what do they do? What happens if you've said these drops should work after 5 days and they haven't? What do they do if the said plan isn't working? And then ideally you want to provide them a summary of what you've talked about, and that can be through patient leaflets, etc. Or just write a small summary if you don't have a specific patient information leaflet relevant to what you've said. In doing this last part, you want to check that there's a satisfactory outcome for both the patient carer and the prescriber, and that the patient has an understanding of all of the discussions that you've had and the actions that are needed, particularly on their part. And you want to talk through with the patient, probably indirectly, their commitment to the management plan. So what do they feel about this? Do they feel they'll be able to take these drops 4 times a day, etc.? And that's where the discussions come in about how you could maybe help them with reminders and help them really take responsibility for their own care. And that's what I'm just saying in this next slide, really. Encourage and support the patient or carer to take responsibility for their medicines and self-manage their condition. How do they remind themselves to take it? Where do they insert the drops, etc.? Do they need help from someone else to come in to help them with inserting the eye drops? So that should all be done in an encouraging and supportive way at that point in time within your consultation. So that was, in general, what should we be doing at the management and advice stage. We're now going to talk about a few more specifics when you're initiating the treatment. And this is engulfed within this parts 4 and 5 that we've already spoken about. So you need to explain the management options and involve the patient in the decision. And that may well include a discussion about the active ingredient, the dose, the form and concentration. So is this going to suit the patient if we have a dosage of 4 times a day, and the concentration and dosage may well depend on each other. And the form, we've spoken about the appropriateness of a spray or a liquid eye drop or an ointment, etc. And then you want to talk about review intervals, why they're important, and how they fit in again with the patient's preferences and lifestyle. Within your discussion about which management choice you're going to go for, you want to get your BNF out at this point. You want to look through in detail the indications, the contraindications, the interactions, cautions and adverse effects of the pharmaceutical, and have a think and a discussion with the patient on how these might have an impact on the patient and the management. So Look through the list, check whether they're on any other medications that might have interactions with the ones that you're thinking about prescribing. Do they have any systemic conditions listed in the section of the BNF that again talks about interactions with certain conditions that a patient might have? If the BNF mentions pregnancy or breastfeeding, that there should be a caution with that. You want to talk the patient through that, talk them through what the actual risks are, and what you want to do in the situation of a patient being pregnancy or breastfeeding. Sometimes the BNF will talk about the need for contraception if there's a risk of cancer to the fetus, etc. So again, you want to make sure that you're discussing all of these things with the patient at the point you're making a decision on which medication to go for. And allergies, you want to ask them about allergies to the specific constituents of what you're giving them. Again, we've alluded to the patient belief about taking medication before. When initiating treatment, you want to tell the patient what the purpose of the medication is, what's the aim of it, and how they will know if it's working, and when it should work. Remember, there's some things where, like the glaucoma meds, where the patient won't know if it's working. They will have no change in any symptoms, and so the patient needs to know that. Equally, if we expect it to be much better in 2 days and the patient's sitting there 7 days later and it's not, we want the patient to understand that that isn't good. You want to explain to them and maybe even show them how to take the medication, particularly eye drops. Actually showing a patient how to put the eye drops in can prevent it just going down their cheek. Talk through exactly when to take it and for how long to take it. For example, keep taking this, don't stop it, contact me if you're thinking about stopping it. That kind of thing would be useful for a patient to know. You want to talk through the patient expected and possible adverse effects, and again what that patient should do if they occur. Don't stop taking it, come back and see me, or if this thing happens, make sure you stop taking it immediately, etc. You want to make a note of any food or other medications or any dietary or supplements to avoid when taking the prescribed medication. And then some more specific, so how are they actually going to get it? Do they take this prescription to the pharmacy, etc.? What do they do if they miss a drop or take too much? Now, the general thinking for missing a medication, and you can probably find a better way of explaining this than me, but if they miss it and they've noticed they've missed it before the halfway point between one and the next dose, then they should take it. So let's say the patient's to take this medication every 2 hours. If they notice within the first hour that they've missed it, they could take it, and if they remember in the second hour, so if it's over the halfway point, they should just wait until they're next supposed to take the dose. And we've spoken about a couple of the other bullet points already. So now we're on to our very last section, specialist communication skills regarding disease and prescribing during follow-up. So now our patients come back to their follow-up appointment. What should we be addressing or talking to them about? Of course, whilst using all of the communication skills we've spoken about earlier in the lecture. So during the follow-up appointments, once you've done your tests maybe, you want to discuss the progressive condition. Ask the patient what they think about how it's been going since the last visit, obviously. And then once you've done your tests, discuss with them how you think the progress of the condition, whether it's recovering as it should or whatever. Discuss the progress of treatment And that's including asking the patient to, this can be really useful, describe how they've been carrying out their medication regime. So it's all well and good for you to say, have you been taking it 3 times a day? 2 drops 3 times a day, etc. They'll just say yes. That's one of the leading questions. If you rather ask them, so say to them, can you tell me how you've been using it? That's a much more insightful answer that you'll get from the patient. And also, it can be very useful to actually get the patient to put one of the drops in, even using saline or anything, for them to demonstrate how they do that, so that again you can catch if they're doing it incorrectly. You want to check the patient's understanding of the condition that they've got, any further questions they've got, and their understanding of the treatment. And then the next step. So as we spoke about for the initial management session, you want to talk about all of the things that are going to happen next with the patient and their treatment. These are some of the GOC's standards or outcomes relating to this part of the patient management. So first of all, they're saying you need to review adherence to and effective of the current medicines. We've spoken about that already. It's important for you to assess adherence in a non-judgmental way. So you want to be approachable, and not that you're testing the patient if they're doing it correctly. You really want them to be able to talk to you if they haven't been taking the medication and say as regularly as they want, and the reasons for it, so that you can actually address these reasons of non-adherence and come to a better outcome, rather than them just not telling you they haven't been taking it and you're then getting a kerfuffle because you think the condition's getting worse, when actually it's because they've not been doing the treatment correctly. And then think about and discuss with the patient how best to support them going forward to improve any adherence. This is just to remind you of what we spoke about earlier. On average, about 50% of patients don't take their medicine correctly or at all. Have that in your mind when you're doing these follow-up visits. So 1 and 2 of them aren't going to be doing it, and then you need to work through how you could improve that concordance. And then again, back to what we talked about right towards the start of the lecture, think about all of the reasons for non-concordance and try to optimise things with your patient. Address the convenience, the forgetfulness, the side effects, anything that's relevant to that patient consultation, so that you can move forward. And remember, again, this is a repeat slide, the patient's perception of your communication is the most important factor in obtaining that good adherence to treatment. So try to give them a good perception and work with them to create an effective consultation for them. The next standard is talking about adverse effects. We've already spoken about this. So during that follow-up visit, look and talk to the patient about adverse effects. And if they have occurred, then you want to recognise those adverse effects and manage them. See how you can either treat that or change your management plan to account for that, and again to improve adherence to your treatment. And then adopt the management plan. You want to think about ongoing monitoring, the monitoring intervals, depending on how the patient's condition is looking today, and also obviously taking into account the patient's preferences as we've discussed. And then think about not just the first follow-up visit, but on an ongoing basis. Establish this plan, maintain it and alter it going forward to be able to help you monitor how effective the treatment is, and also any unwanted effects that might arise throughout the treatment period. And again, this is similar to one of the slides that you saw in the initial treatment section, and you've seen this a couple of minutes ago actually, haven't you? So Just in summary then, discuss the progress of the condition, discuss the progress of the treatment, check their understanding, and talk through the next steps. Well done, that's you got to the end of your hour and a half. So we've covered all the way through from why communication is important, communication techniques throughout the consultation, and then we've spoken about history and symptoms and management and advice. So if you just cast your eyes over the learning outcomes again, hopefully now you can have a better understanding of the key aspects of communication during a consultation. Hopefully you understand how to communicate effectively with regard to disease and prescribing medications, that you understand how to adapt the communication relevant for specialist diseases to take account of patient needs and beliefs, and then how to work with the patient or carer in partnership to help them make informed choices in exploring their understanding of a consultation and the risks/benefits of treatment. And that's us. Thanks for listening, folks. We'll see you all soon.